I know that the messaging to women has been incorrect, and how to educate our girls and how to educate the younger generation and ourselves. Hello, everyone. This is Dr. Din at your service, and we are here today because we're going to be talking to Dr. Sadaf Lodhi, our gynecologist, who is an expert in all women-related issues, especially intimacy-related issues. But today, we're going to talk on a variety of topics, including the fact that she just recently did a fabulous TED Talk and about something seriously important. And we want to see all the things that she would like to talk to us about in the limited time that she has with us today. So our expert, Dr. Sadaf Lodhi, and I have like a series and string of questions, which I'd be very happy to share with all my viewers. And I am sure Dr. Lodhi has thousands of followers on who follow her every single day, and we benefit from her content every single day. Dr. Lodhi, please welcome. Thank you for coming on this beautiful Sunday morning. And how are you? And let's chat about women health issues.
Thank you for having me on, Dr. Dean. I appreciate it.
So tell me more about yourself. Walk me through how you got interested in women's affairs. I mean, I understand you're a doctor, so like as a doctor, we wear many hats. But what brought you to just niche down on GYN and then intimacy issues?
Right. So I am, just for your viewers and listeners who may not know me. So my name is Dr. Sadaf Lodhi. I'm a board certified OBGYN, and I have been practicing obstetrics and gynecology now for outside of residency for 19 years, and then including residency for 24 years, I think. And so anyways, basically what I was always interested in women's health, and that's because I always felt that in some cultures and communities, women were not, I felt like they were kind of in the background and in the shadows, and really didn't get as much attention as they deserved. And then I also felt that growing up, I didn't really have a role model that I could look up to or that I wanted to be like. And so I wanted to be the role model that I never had. And so I went into obstetrics and gynecology simply because I felt like I wanted to advocate and give voice to women. And so
Were you born and raised here?
No, so
The United States?
No, I was born in Pakistan. I was born in Multan. And then it came over when I was about 3 years old, and then went back and came back when I was 5. So I've been here since I was 5. And so, so I did all my schooling actually in Michigan. And then I went to the University of Michigan for undergrad, and then Michigan State University for medical school. And then I did my residency out there as well. And then I came out to New York. So then I would say about 2 years ago, I felt like I really wanted to focus on, I was always interested in women's health and gynecology. And then about 2 years ago, I felt like there was a huge void in sexual medicine because we as physicians don't really learn about sexual medicine. And I felt like I wanted to fill that void as well as with menopausal health, right? So when we're younger, we don't really think about menopause and we don't really think about the changes that happen. And it's a big deal. And actually with the whole WHI study in 2002, and we were all of a sudden taught like, don't prescribe hormones, it's not good, and this and that. And so, it causes breast cancer, whatever, and which is all not true now, we know. But, there's a whole generation of OBGYNs, me included, that did not feel comfortable prescribing hormones. And so then
Dr.
now,
Lodhi, you look amazingly young. I know that you just told us that you've been a doctor for like how many years and stuff, but tell
24.
me a little more about like how so here you went into you did your GYN and everything. This is like around what year? Because you the practitioner of the OBGYNs who told us not to take hormone replacement and stuff. Did you ever practice that?
Yeah.
I know
So,
you look
when,
very young. Like I know for sure that you're younger than me because your children are much younger than mine. So
yeah. So in 2000, so I did residency in 2000. Okay. So
okay,
2000 to 2004 is when I did
okay.
residency. And at that time in 2002 is when the WHI study came out. And that was when they were telling us not to prescribe any hormones to women. And they said it caused breast cancer and all this stuff, which we know is not true. But that was the year. So then, all of my attendings who taught me told me, don't prescribe hormones. And so we just never dealt with it. We never dealt with menopause. We never really learned anything, and then as we get older as physicians, right, and as women, as we get older, we start going through perimenopause and menopause and all that stuff, and then we start to think like, wow, there must be more out there. What is going on with me? What are the changes that are happening? And so it was really for my own information and research that I started to look more into menopause and realized that, all the things that we had been taught were really not true. And, estrogen in most cases, I'm not saying all, obviously, anyone that's listening to this would have to go and see their own healthcare provider to make sure that there's no contraindication to hormones. But for the majority of women, hormones are very safe, and especially vaginal estrogen. You want to make sure that you take vaginal estrogen, place it inside the vagina for really your whole life, forever, to prevent
What?
to maintain your vaginal estrogen is very safe. It's not systemic, it's local, and it maintains the bladder health, it maintains your vagina, prevents recurrent UTIs. I mean, vaginal estrogen
At
for
what
and
age would you suggest vaginal estrogen? And that was one of the questions somebody asked. It was like how difficult like is it what are your opinions on vaginal estrogen and when to start it? Because one of the questions that we have for you is at what age would you start checking a woman's hormones, and tell us more about like how the hormones changed from puberty to perimenopause and menopause and after. And there was like very important, one of the things that got me like very interested in speaking to you regularly hopefully is that when you said that half of like women spend half of their lives in menopause and nobody teaches us how to prepare for it and how to deal with it.
yeah, no, it's
And what
true.
is a good way to at what point should I check the hormone status of my daughter who's in her 20s?
Yeah, so no, definitely you don't need to be checking, So one of the biggest signs, right? So usually the first sign that we have that somebody may be starting to go through perimenopause is really changes in their periods. Okay, so when women start experiencing like, so now we also have to be careful because there are some women that have polycystic ovarian syndrome, right? Which is where they skip ovulation in a few months and they have increased insulin resistance, and so that's a whole different subsect of women. But for women that have regular cycles, that have a period every month, let's say that cycle can vary anywhere from 21 to 35 days. If they notice that their periods are going longer, right? So they're going longer in between the start of one period to the start of the next period. So they're skipping months. Or their period is happening much more frequently. So say they're getting it like every 2 weeks, right? That they're actually having a full blown bleed, and so that is usually the first sign that we see in terms of women going through perimenopause. And that can begin at really any time, but typically happens in a woman's 40s. Okay.
I see.
So what's interesting to understand is that there's a study called the SWAN study, which was started in 1994, and they have it's a multi-center study. So they have different states, so different I would say hospitals are involved throughout the United States. So there's a location at the University of Michigan in Ann Arbor. There's one at Brigham and Women's, and there are several other sites that they have. And what they've done is they have been studying women since 1994 across their lifespan to see what happens to women during midlife. Okay. And what they realized is that perimenopause varies for women, and it can vary based on ethnicity, which is something that's pretty recent. Before, they used to tell us that, perimenopause happens a few years before, typically like 7 years before menopause. Menopause, we know, is what we call a retrospective diagnosis, meaning like you have to go a whole year without a period to be diagnosed to be in menopause. So really a woman wouldn't know that until she's gone a whole year without a period, right? So that's why we say it's a retrospective diagnosis. And so for most Caucasian women, the mean age for somebody to go through menopause is around the age of 52, 51 or 52. But the time span of a woman to go through perimenopause. So perimenopause is a time where, you have irregular menses, you can have a lot of brain fog, and a lot of women. There was an article published in the New York Times this past, I believe it was either February or April of this past year, where the author of the article from the New York Times, so the journalist, says that her first symptom of perimenopause was actually brain fog. Okay, so the symptoms for perimenopause are going to vary for everyone. And for some women, it's brain fog. As for other women, it's irregular menses. For other women, it's joint pain, decreased libido, anxiety, depression. We know that women will have a 1.5 to 3 times more chance of exhibiting symptoms of depression, either recurrent or new bouts of depression during the perimenopause phase. And the reason for that is because we know that there are lots of estrogen receptors throughout our whole body. So really, like anything that you can think of probably has estrogen receptors. We know that there's tons of estrogen receptors in the brain. So when we have that hormonal fluctuation that happens in perimenopause, where we have, estrogen, then our estrogen drops, and that's because of the ovaries. And really, so we have the hormone FSH that comes from the hypothalamus, right? And it acts on our ovaries, and our ovaries will produce the estrogen. But what happens is that hormone is constantly like triggering our ovaries to produce that estrogen, but eventually our ovaries stop producing estrogen, or very little of it. And so that's why that hormone level FSH goes up, because we know there's a negative feedback loop in medicine. And so if something, you're going to keep pushing on something to get it to work, right? Yeah. And so with us, that's in reference to our ovaries. And so that hormone keeps is trying to stimulate those ovaries to produce that estrogen, and it'll produce, but eventually it's going to stop. It's going to stop producing that estrogen. And
so where is progesterone in all this? Like, I thought that this perimenopause and this being a woman is like this intricate tango between estrogen and progesterone.
Yeah. Mostly we look at estrogen levels. You can also look at progesterone levels. Progesterone levels tend to go up with ovulation, right? So if we don't have ovulation, happens when you release an egg, right? And you have all women throughout the world, like in the world, have a set number of eggs, right? And even that we're born with, right? And eventually, as we go through our lifespan, we release those eggs, right? And those eggs are released when you have that LH surge with that progesterone. And so if you are no longer releasing eggs because you're running out of those eggs, because that's just a normal physiologic thing that happens, right? When we stop ovulating, if we're going to stop ovulating, then we're going to stop releasing that progesterone.
I see.
Right? So progesterone is also involved with sleep. So when we have issues with sleep, it's going to be affected when we have a decreased progesterone. And so a lot of times menopause practitioners will give progesterone with estrogen. Well, the reason why we give progesterone with estrogen is because, especially if you have a uterus, right, is that you want to prevent unopposed estrogen. So you want to prevent that tissue of that lining of the uterus from growing too much, what we call hyperplasia, and so that prevent endometrial cancer, right? We don't want to give estrogen by itself unless you no longer have a uterus. If you still have a uterus, you always need to take progesterone along with the estrogen to prevent that from happening. And what progesterone does is it decreases the lining of that uterus, okay? So that you're not having this irregular bleeding, and also that you're protecting the uterus from the effects, the unwanted effects of estrogen. Estrogen, is the FDA approved medication that we have for hot flashes and night sweats, and it's FDA approved for osteoporosis.
So one other segue, I just want to not forget to ask you this. Does our use of birth control throughout our 20s and 30s have any impact on how we experience perimenopause or even menopause or after?
Yeah, I would need to look that up. I don't think so, though. I don't think that has any effect on it. I think that what happens is, again, when we are going through perimenopause and menopause, that has to do with our eggs, right? And running out of those eggs and not ovulating and not having those eggs that are being released from the ovary. And so one other thing that I was talking about with that whole study from the SWAN study in 1994 that is still ongoing. So it's it's a study that's still there. Is that they're finding out more and more things. And one thing that they've noted is that perimenopause varies for women of different ethnicities. So that's actually what I was getting to. And what they noted is that for African American women, they tend to experience perimenopause for the longest amount of time, which is about 10 years. Okay. For Latina women, so they start earlier and they go longer. For Latina women, it's about 8.9 years. Again, same thing, is that they tend to experience perimenopausal symptoms, which can be hot flashes, night sweats, mood swings, anxiety, depression, brain fog, joint pain, all of that stuff. And they can experience it for a longer amount of time. In terms of what we say Asian women, and we think it might be because of their diet, but they tend to experience perimenopausal symptoms for the least amount of time, so for about 5 years. Right. So what I wanted to say is that for Asian women, they tend to go through perimenopausal symptoms the least amount of time. And for African American women, they brought up a concept which I thought was very interesting and makes a lot of sense. And they mentioned it again in that New York Times article as well, is that there's something called weathering. And weathering is when a subset of a population, right? And so here we're talking about a race such as African Americans, when they have experienced generational trauma, for example, slavery and oppression, then that actually gets imprinted into the DNA of individuals. And so because of that, they believe that that's why African American women and Latina women tend to experience perimenopausal symptoms for a longer period of time.
Wow.
Generational,
intergenerational trauma.
Right. The generational trauma changes the DNA. And actually, there's been studies on this, and they say the same thing for Southeast Asians and their risk of cardiac disease. You may know that, Indian Pakistani people, specifically men, tend to have, that's actually a risk factor, is them just being of South Asian descent, for having increased risk of cardiac disease. And they think the same thing. They think because of the colonialism that the British brought over to the subcontinent, they believe that changed the DNA and has made Southeast Asians more at risk for cardiac disease.
What about patriarchy? Does that have anything to do with trauma?
Yeah, I don't know. I mean, I'm sure it probably does. I don't doubt it, but I don't know. I can't really say to that. There is one thing that I just wanted to look up real.
Another question was that, okay, so what are the things? So I understand now that perimenopause can last for somewhere. It's like a bunch of differing kind of different symptoms like sleeplessness or body aches and pains, and sometimes depression, and the shortening of period. So instead of getting it for your routine 4 weeks, it could be like 3 weeks or 2 weeks. And this symptomatology can go on for like maybe 10 years max, and from anywhere from a few years to 10 years before you experience menopause.
Yes.
And that is where, and but what I am understanding is that, so you feel that when you start experiencing the perimenopausal symptoms, which also you mentioned, not to let me not forget, is like the brain fog and forgetfulness that women have. And so one of the things that we can start to improve our symptoms of perimenopause is to start estrogen, vaginal estrogen at least.
Okay, so there's two
That
things. So vaginal estrogen is not going to help you with all
the
of the
perimenopause.
symptoms in perimenopause that you're
Yeah.
experiencing, right?
Yeah.
Let's see here. Sorry, I just want to look
Yeah.
up
So one
something
of the
really quick.
questions was that, are there any supplements? Are there any, um, does your gut microbiome have anything to do with your perimenopausal symptoms or menopause? And what are the ways? What can we do? What do I tell my clients who are coming in perimenopause and menopause?
All right. So in terms of, okay, so let's talk about first about the hormones. So you wondered, why or when. So the question is, at what point do you start estrogen or progesterone, right? So I think for a lot of women, they can start taking them depending on how their symptoms are. But for some women, they can even start taking estrogen and progesterone when they're going through perimenopause. Because remember, in perimenopause and in menopause, you have the hot flashes, the night sweats, the mood swings, and all of that thing, right? All of those things going on. And that is due to the fluctuation in the hormones and specifically estrogen. Now, if we increase or we start giving medication during that time, that will help. And remember, estrogen is the only FDA approved medication right now, but actually there is a non-hormonal medication as well, which is called Vizoa, which helps with hot flashes as well. But estrogen is FDA approved for hot flashes and night sweats and for the prevention of osteoporosis. According to the North American Menopause Society, women can start estrogen therapy, right? Who are candidates. And remember, it's important to check with your provider before you start taking any type of hormones. But women that are candidates for estrogen therapy are those that have within the first 10 years of menopause. So within 10 years of going through menopause, and for those that have that are less than 60, then age less than 60. And the reason why they say that is because they haven't found, they find that there's more of a risk of starting hormones after the age of 60 as opposed to before the age of 60. So that's when it's encouraged. Like if you decide you want to go on hormones, then that's the age range for you to go on. Now, in terms of, you're talking about vaginal estrogen. Remember, vaginal estrogen is not systemic, meaning like it's not going to help you with all the symptoms and it's not going to go all throughout your whole body, right? So the vaginal estrogen is specifically for the vagina and the vulva. You take the cream, you put it inside of the vagina, and it helps with elasticity. It helps with increasing blood flow to that whole region. And so that's why you're doing it. It prevents recurrent UTIs. It helps with the bladder health. So that's why you need the vaginal estrogen, and you want to take that like literally forever. In terms of systemic hormones, so you're talking about either taking estrogen, you can take it as a cream, you can take estrogen as a patch, you can take estrogen as a pill. And they found that the least amount of risk is with taking estradiol patches, so as a patch or as a cream. By taking it orally, you have the first pass effect, meaning like it has to go through the liver first, and so that can cause some changes in your cholesterol, and it can have a few other changes. So and especially if there's any history of fatty liver disease or something like that, or anything going on with the liver, you may not be a candidate for estrogen therapy. Okay, yes. So that's important to remember.
I see. So other than estrogen, any other supplements that can help with the biome? Like does the gut biome or microbiome have any impact on this? Because I did hear that there are some studies where they're studying this, but they haven't found anything. But I'm sure that there are supplements that we give. And
so I don't know of any, and so I'm not going to pretend that I know. I don't know if there's any connection between menopause and the gut biome. Perhaps there is, but I don't know. And in my reading and for the test to become a menopause certified practitioner, they did not mention it. So maybe that's an area of research that's ongoing, but I don't know of a connection between menopause and perimenopause and the gut biome. Definitely there's a connection between skin health and gut biome that I know of, but I don't know of between menopause and, I'm not going to be surprised if
I studied. I was studying Dr. Sarah Gottlieb, who is a doctor in she's GYN and in Stanford, and she has written a couple of books also on this. And I was actually listening to a podcast of hers while preparing for your interview, and I one of the things that she mentioned was how she checks the nutritional deficiencies in women, which start manifesting themselves when they're very young, like in their as young as in their teens. And one of the things that they said is that basically those are the areas where your teenagers, how to teach them how to supplement and how to improve their nutrition, and may improve their symptoms much later in life, like when how they face different phases of their womanhood, and how to change their trajectory earlier on in life with the things. So this is like some ongoing study that she has been publishing on, and I think that one of the things that she mentioned was that glutathione, she mentioned, is very important to start early. It's like a detoxification principle and she has like some very intricate protocol for that. And then also magnesium, she was saying that, to help with your sleep issues and stuff like that when you're going through perimenopause. Because one of her talks that I heard was where she said that she has been now in perimenopause for 20 years because of the menopause. She has been delaying it because she just has been supplementing and stuff.
I don't know anything
but
about
I guess that's something that needs a lot of study, I guess.
Yeah. So in terms of supplements, I know that there are some people that do advocate for like omega. So there are, I know that there is omega-3 fatty acids that they recommend in perimenopause. Also, magnesium definitely is also recommended, and a few other supplements, but I don't know all of them.
I see. Yeah, no. I think having sex and successful sexual experience probably comes as a culmination of hormonal balance.
Yeah, so actually, when we talk about sex, in perimenopause and menopause, a lot of times women will experience decreased libido. And, that has a lot to do with the fluctuations in the estrogen. And also, women will start to experience genitourinary syndrome of menopause, which is where you get the vaginal dryness, you get the itching, the irritation, and also your vulva and your labia start to regress and they start to become smaller. The introitus, the opening to the vagina also starts to become smaller. And so to prevent all of those changes from happening, you definitely do want to use vaginal estrogen because that'll increase the blood flow and it'll prevent everything from starting to shrink. And it's almost like, well, it is, you go to a hypoestrogenic state, which means that, you don't have the estrogen because of the decreasing estrogen that happens in menopause. And it's almost like a young girl that has not gone through puberty. You see that the labia and everything's really small, right? When they are young. And then once they start to go through puberty, then everything starts to become larger and the labia form. And so it's almost like we go back to that same stage when we enter
Yeah.
menopause. So that's
Life
why
is a cycle.
yeah. So that's why it's super important to be using that vaginal estrogen because it's going to continue that increased blood flow to the vulvar region and prevent the pain that a lot of women have with sexual intercourse. It's also going to help with lubrication. And when we talk about sex in menopause, it is helpful to realize that you can use lubricants, you can use moisturizers, but really the gold standard to help with pain with intercourse and to help with the blood flow and the lubrication is to use that vaginal estrogen.
Tell us one thing about, like, so again, there is like this intricate tango that's going on between estrogen and progesterone, and we are supplementing ourselves with estrogen and maybe some other supplements that we've heard of. But what else is there? Like, what is the role of testosterone in all this? And then how do we manage for women the testosterone that the ladies were on it? Like, how often should we check them? And then what are the different forms of testosterone?
So, in terms of testosterone, that the impact that plays in a woman's life is really a lot of times that helps with libido. And so in postmenopause and the perimenopausal phase, when a lot of women are experiencing decreased libido, women are often, they're given some estrogen, progesterone, but also, they can be given some testosterone, and testosterone definitely helps with libido. It is something that is off label, that is used in women. We do have two medications that are FDA approved for libido, and one is something called Addy, which is a medication that is it acts in the brain and it is taken daily. I believe the dosage is 100 milligrams at night daily. And then there's another medication called Vyleesi. Now, Vyleesi is an auto injector that you inject about a half hour to 45 minutes before planned intercourse. And sometimes it can cause some nausea. And so you can give like an antiemetic or, something to prevent the nausea before you take it. And that also is FDA approved for libido. Testosterone is used off label. And we typically don't encourage, so the North American Menopause Society, along with the American College of OBGYNs, do not endorse pellets. They don't like those because we don't know exactly the dosage of the medication that you're getting in each pellet. It's not FDA approved. The way that they use testosterone is the cream form, and you can do a tenth of the dosage that is recommended for women. For men. So a tenth of the dosage that's recommended for men. And you have to measure those out. And you can use that to increase libido. So it is a cream that you would apply.
Why anywhere?
You can apply it to the clitoral region, or you can apply to like the back of your, I would probably suggest to apply it to like the back of your thigh, somewhere such as that. What happens with if you apply it to the clitoris, you can get, it's unlikely if you use 1/10 of the dose recommended for men, but you need to go to somebody that will monitor you for testosterone levels. And you can get blood work probably monthly, depending on how often you're using the testosterone. But you want to make sure that you don't start to experience those side effects of testosterone, which can be, and this is only for more than therapeutic doses of testosterone in women, but you can get like male pattern baldness. You can experience deepening of the voice, you can experience acne, you can experience clitoromegaly, and sometimes these side effects do not reverse. And that's why testosterone, although it can be used in women, you should really go to a practitioner that knows how to use it so that you don't experience any of the side effects that can be associated with super therapeutic levels of testosterone.
So do we trust the blood hormone levels? I mean, should I have sometimes I feel that when we're checking somebody's levels through their blood, it's been 2-3 seconds of an injection in one vein is not going to give you like what your body is experiencing as a whole. I mean, is it better to check salivary or like maybe urine levels?
No, we go by blood.
By blood.
We don't check salivary or urine. But I also want your listeners or viewers to understand that, libido is complex. It is one of the most common reasons why women come to a practitioner, why they go to their doctor, to their gynecologist, whoever. And that anytime you're talking to somebody about libido, it has to be in the context of what we call the biopsychosocial model. And so in sexual medicine, we use the biopsychosocial model as a way to figure out what exactly is going on. And you also have to understand that, the sexual response in a woman is not linear, but it's circular. And that was research that was done in 2001 by Rosemary Basson, which she included, spontaneous desire, responsive desire. She also included emotional intimacy. And what she realized with her research is that oftentimes women as they go into like a long-term relationship will often not experience spontaneous desire, but it'll be responsive desire, meaning that once they see the sexual stimuli, then they start to become, have the desire and start to have arousal. As opposed to what you see on images in TV where it's always spontaneous and people are just throwing, each other's clothes, tearing each other's clothes off and this and that. That's typically not what happens in a long-term relationship, and that, it can take some time, and to have responsive desire is normal. And there's nothing wrong with somebody if they have responsive desire as opposed to spontaneous desire. But also the biopsychosocial model talks about, looking at a person holistically and looking at what's happening to them biologically, psychologically, and socially.
You're reminding me of this TikTok trend where the guys are saying that, in order to get her in the mood, they're like doing the dishes and they're doing the laundry and they're like setting up, like in a long-term relationship, you have to make her feel less tired before you expect her to also have get in the mood in preparation to get in the mood. So you mean it is possible that it a long-term relationship to also love the person and also want to have sex with that same person over a long period of time? It's like, is it a and then now, like I see that women, so men go through. I tell everyone that men go through also a menopause, like an andropause, where but they have like these. They get help with medications like testosterone and Cialis and Viagra and whatnot. And women now also have their own versions of Cialis and Viagra, which, of course, I mean, I'm sure they're not covered by insurance, and estrogen maybe.
Okay. So what we talked about before is that, right, there is medication for libido for women, and that's that the Addy and the Vyleesi that I spoke of, and
Yes.
off-label using testosterone. So those are the 3 medications that we have to help with libido. And in terms of whether or not it's covered by insurance, I mean, I think that is a case by case scenario, and you just have to figure out whether or not your insurance covers it. Again,
so they should I should send them to you, like if somebody is having libido issues or perimenopause and menopausal issues, so we have to find like somebody who's in a sex coach or like a doctor who does this.
Yeah, I mean, so there's a lot. So I think that when people have issues with sexual health, I don't think it's a quick fix. I think that it's really important to fully examine the patient, make sure that they're not experiencing pain, right? And then, I mean, there's so many things. So you want to make sure that they're anatomically, they're fine, that they're not experiencing pain. People can have vulvodynia, they can have vestibulodynia, they can have chronic infections, they can have lots of things that may be going on. And I'm speaking of specifically about women because I focus on women, cisgender women specifically. But, in terms of for men, they would do the same thing. They'd go to a urologist. They'd want to make sure that, anatomically everything was okay. Remember that if a man is not able to have an erection, we have to also be worried about his cardiac health, right? Because the small arteries in the penis are one of the first things to be affected when a person has cardiac disease. So if a man is not able to have an erection, then you should also send him to a cardiologist and have his heart evaluated. So that is something that's really important to understand. Also, a lot of times with men, they have anxiety over performance issues, and so that can be a factor also in decreased libido. So there's lots of things that happen. And I think that with sexual medicine, it's really important to see somebody that has been trained in sexual medicine and that understands that, it's not just a matter of giving a man a blue pill or a woman giving her Addy and saying like, okay, that's it, go drink some wine and you're going to be fine. That's actually very patronizing, and it's not a good way to handle somebody that may have been experiencing pain for a long time. I think that pain is a real issue that some women experience, and could be due to abuse, could be due to trauma, could be due to chronic infections. There's lots of reasons, could be hormone induced. And so it's really important to be evaluated by a practitioner that understands what you're going through.
But, I was listening to your TED Talk, and I know that we're completely out of time. But I know I was listening to your talk, and then here you were telling everyone, and I cannot repeat it, but it's basically what you said is that the practitioners, the people that we're going to send our clients to, are not trained in this information.
Correct. Yes.
Because we're not taught in med school, we're not taught in residency programs, we're not taught. So you went and you learned this yourself.
Correct.
Yes. Were you taught as a gynecologist about sex issues, sex-related dysfunction?
And that's what I mentioned in my TED Talk as well, is that being a gynecologist, you would think that we would be taught sexual health in residency, and we're not, which is really unfortunate. I think now perhaps maybe some residencies are doing a better job of teaching their residents, at least the basics about sexual health. But I know that most residencies still do not even talk about sexual health. So it becomes a big problem. And it's really, if you are really interested in sexual health, then you have to make an effort yourself. So I actually did a year-long course with the University of Michigan for sexual counseling and education. I also became an ISHWISH fellow, which is the International Society for the Study of Women's Sexual Health, and they offer courses. And they also, they have an annual conference that people go to. So it's really important that if this is something that you're interested in, then, you go and get educated on the topic.
So, I mean, as a doctor, it took me several decades to get to the point where I realized that how important sexual activity is for the wellness of a human body. And I know that but like also how we it's a matter of perception. Like women were taught that okay, menopause will happen and then you will have no desire, any further desire is done after that. And then here we are, women are living into their 80s. And I was very happy the other day to look at some very important women like Martha Stewart the other day was talking very openly about how important it is to have sex, and she's like over 80. So I know that the messaging to women has been incorrect. And how to educate our girls and how to educate the younger generation and ourselves. There are some questions here. Can someone in their 30s experience dryness? This is someone asking.
Absolutely.
And also
Absolutely.
there's like I think empathy and compassion to the partner is also important in sexual activity.
Right. And so, that's where going to like a sex coach or a sex therapist would be very helpful, because if you are, so, we have to remember, and we say this all the time in sexual medicine, that the biggest sexual organ is actually the brain. Right. And so if you are, and there's so much, and then we could go on, but there's something also called arousal non-concordance. And what that means is that, you can be sexually aroused, but your body doesn't follow. Like physiologically, you may not be lubricated, right? Or you may be lubricated as a woman, but may not be interested in sex, right? So that's called arousal non-concordance. It can be the same thing. So just for me to give you an example of this, maybe that, a boy that is in a fraternity in college, right? He sees something where he sees a woman get assaulted or get raped. And because he sees that, he has a physiologic response. So maybe he has an erection, right? But then he feels guilty because he thinks that even though it was something horrific that he witnessed and he was not happy about it, he felt like he couldn't report it because he had a physiologic response, not understanding that that was just his body responding to a sexual stimulus, not that his brain was saying that it was okay. Does that make sense? So just because his body had a physiologic response did not mean that he wanted to have sex.
Yeah.
Okay, so that's called arousal non-concordance. So it's basically when your body responds to a sexual stimulus, but your brain is saying something else. Same thing for a woman that may be getting assaulted, that, the person that's assaulting her says, oh no, you're enjoying this because you're really lubricated, right? And she's saying, no, I don't. But it's just because her body is responding to a sexual stimulus. It's not that she's enjoying what's happening. So I think
the pleasure in the experience and the brain, it may be experiencing the symptoms of that pleasure in a different way.
It's not pleasure. See, that's
also it's not pleasurable to the brain. It's not pleasure
because the brain, it's not something that the brain wants.
So there's a non-concordance, I guess. I get it.
Right. Yeah. Because it's the body that is physiologically responding to the sexual stimuli, but the brain is not enjoying it and the brain doesn't want it. Because of the
guilt, or because brain doesn't perceive
if a woman is being assaulted, good. She's not having guilt.
Yeah.
She's not liking what is happening. So she is upset, but her body is responding to what's physically happening to her body. Does that make sense? So same thing with the man that sees an assault or rape happening. He's not enjoying seeing what is happening, but his body is responding. So he feels guilty about what he sees because of the way his body responded. So he doesn't report that incident to the police because he thinks he enjoyed it, but he didn't. Does that make sense? Anyway, there's this whole thing we can talk about it another time, but it's called non-concordance. And it's basically where the body is responding to a sexual stimuli. So the body is doing what it does when it experiences something sexual. But the brain is telling you that I don't like this. This is not what I'm enjoying, and this is not what I want to do. Okay, so
Yeah.
there's a difference. So I think that that's really important, because that plays into the idea of consent, and how consent is very important when people are seeking out pleasure in their sexual activities. So I think that that's something that's really important.
Their own consent or societal consent, that's
No.
like another layer of.
No. We're not talking about society. We're talking about consent between the two individuals that are participating in the sexual activity.
I see.
You're talking about consent. You're talking about making sure that the person that you are having a sexual experience with also wants that sexual experience. So that's why it's really important to talk about that with high school.
That's
kids.
like a whole episode again with you.
Yeah.
So we haven't again, but thank you so much, Sadaf, for doing this, and get me on your schedule again. And I need another episode to this.
Thank you for having me.
Thank you everyone for joining.